Am I audible, ma'am?
Audible, Lewis, you can start. Yeah.
Thank you, ma'am. A very good morning to all the dignitaries who are present here, our esteemed alumni, principal madam, and our very esteemed speaker for today, Ms. Amandeep Kaur. So we are here to host, excuse me, we are here to host the third webinar series of the alumni uh, webinars. And today the topic for the webinar is improving clinical practice using simulation in nursing education. And before we go into introduction of the speaker, I would like to request our respected principal, ma'am, Dr. Lata Venkateshan, to say a few words. Ma'am, please.
Thank you, Lewis, and a very warm welcome and good morning to all the participants and the alumni speaker, Amandeep Kaur. The AIIMS College of Nursing was started in the year 1969, and the alumni of AIIMS College of Nursing are placed in illustrious positions all over the world. And we were just taking the initiative to get connected with our alumni members. And we want the alumni to speak to the current generation of students to inspire them how they have grown in their profession. And it will be a kind of motivation and role model for the students to follow. They can dream themselves one day where will they reach like their seniors. So with that objective, this Alumni Speaks webinar was started, and today we have Amandeep Kaur among us. When we started this program itself, she volunteered that she will talk on simulation-based education, and we are really happy that she is placed at national level, National Simulation Center, which is being hosted by Indian Nursing Council along with SGT University. And she is involved in training many people over there in simulation. And we are very proud she is the alumni of 2013 batch. And there are several other alumni who are in significant positions. And we will be getting connected, and it is very nice to get connected with our alumni because we get a feeling of being together in the family. So I welcome Amandeep Kaur and I welcome all the delegates who are attending this program by her session. And a weekly once an alumni will speak, so stay connected with us. And I must thank Lewis for taking initiative to coordinate this Web Series 3 program. Thank you, Lewis, and best wishes for today's webinar. Thank you.
Thank you, ma'am. So to introduce our speaker, can you please project the slide on the introduction? Okay. So Ms. Amandeep Kaur, she is an alumni from the MSc batch of 2011 to 2013, as Principal Ma'am has mentioned. And she has done her master's in neurosciences nursing, and she had an excellent academic record during her student days. And she is the master trainer for simulation training and skills update under capacity building program of midwifery faculty by the Indian Nursing Council and UNFPA. Currently, she is working as the assistant professor cum simulation lab training officer at National Reference Simulation Center at SGT University. And as we all know, this simulation center has been used to train the nursing faculty from all over the country, and we are very proud of her. And she has been a resource person for many national programs and trainings, and she has a number of paper presentations and publications to her credit. And she is also an active member of a number of professional organizations, and she is always ready to contribute for the nursing profession. And with that, I really am grateful to Ms. Amandeep Kaur for having accepted this invitation to be the speaker today, and I hand over the mic to her. Thank you.
Thank you, ma'am, for the wonderful introduction. Can you hear me?
Yes, Amandeep.
Yes, ma'am. So, good morning to everyone. First of all, I would like to thank Dr. Lata Venkatesh ma'am, Principal AIIMS, for giving me this opportunity. And I also congratulate her for coming up with the brilliant idea of making this Telegram group of all the alumni of AIIMS and initiating these alumni webinar series. I'm sure we'll be able to share our knowledge and experiences through this platform. So the topic of today's session, as Levis ma'am has already told, it is improving the clinical practice using simulation in nursing education. So before I start my talk, I would like to show you a video on simulation scenario. It's a short video. It's not the complete video of the simulation, how it occurs, but it is just a part of simulation scenario. So I'll be sharing my screen. Ma'am, can you see my screen?
Not yet. Not yet. Amandeep.
No, keep your slides open and then click on share screen.
Yes, ma'am. Can you see the screen now?
Yes, yes, it is coming.
Yes, ma'am. Are you able to hear also, ma'am?
Yes, it's audible.
Okay, thank you. Mhm. So this was just a trailer of the simulation scenario. It is not a complete simulation, but just a part of the simulation. And the actors who played the role in this simulation video were students of STT University only. Can you see the PPT, ma'am?
Yes, yes, Amandeep.
Okay.
You can make it full screen.
Yeah, I have made it full screen.
We are not able to see full screen. Can you just close the full screen and do it again?
Okay, ma'am. Ma'am, now can you see full screen?
No, it's still not in full screen mode.
It is visible. Screen is visible.
Yes, it is. You can go ahead. Like this.
Oh, let's have to pin her screen. Maybe you are pinned to her. That is very not visible.
Okay, ma'am.
Okay. Yes. It is visible. Continue.
Okay, ma'am. So, as I said, that video is just a part of the simulation scenario. It is not the complete simulation, and simulation is much more than that. And the topic of my today's presentation is improving clinical practice, as ma'am has told, using simulation in nursing education. So, before I move further, the objective of my presentation is that participant will be able to discuss the need of simulation at the end of the presentation, define simulation, explain the structure of simulation, and also enlist the characteristics of a facilitator. So it is.
Excuse me, Aman.
Yes,
Your slides are not moving. Maybe you can mail me quickly.
ma'am, I have mailed you. Just a second. I will share my whole. Yes.
You select entire screen and share.
Yeah, that's what I will do. Select the entire screen. Now, can you see the whole screen?
Yes, it's perfect now. You can do slide share.
Yes, ma'am. I'm doing.
Great.
Now it's moving, ma'am.
Yes, it's moving.
Okay. So, as in the video, you have seen that medical errors are not very less. They are very common. So, to err is human. It is commonly said that it is normal for human being to commit mistakes. Similarly, people who are working in healthcare industry, they also commit mistake at some point in their life during their work time. But these medical errors we cannot afford. We cannot afford these medical errors because it risks the life of the patient. So the Joint Commission on Accreditation of Healthcare Organization and WHO, they have concluded that medical errors happen in 1 out of 10 patients every year globally. But in India, 5.2 million medical errors happen annually. It is given by the study conducted by Professor Jha in Harvard. So medical errors are very common. So let us first understand what is Henrich's model. So in Henrich's model, you can see that the Henrich ratio for medical error is 600 is to 30 is to 10 is to 1. Means for 600 non-reportable incidents, there are 30 reportable incidents, and for these 30 reportable incidents, 10 are accidents. And among these 10 accidents, one is a fatal accident. So if we club these two things together, the reportable incidents and non-reportable incidents, they are the medical incidents, they are the medical errors. And if we can reduce these medical incidents or the medical errors, we will be able to have a reduction in these accidents. Okay, so a healthcare professional, they were found that they are not very up to the mark, or we say they are deficient in performing the clinical skills, problem solving, and application of information, though they have a sound knowledge base, but during any critical situation, sometimes when they are under stress, sometimes when they are having lot of workload, they are not doing the skills up to the mark. They are forgetting things. They know it, they have the knowledge, but they again commit errors. So simulation, here comes the role of simulation. So simulation can actually create a required environment or the skills needed for the learners to attain that competence, attain that confidence in the larger extent. So these are certain studies which I have taken from the Google only. So simulation is not new. Over the past 2 decades, simulation in medical education is found to improve the patient safety and reducing the medical errors. So here you can see that not only nursing education, but the whole healthcare environment, the simulation is helpful in improving the patient safety. So this is one study which was done on nursing students, and it has also shown that if we are teaching the simulation, if we are teaching the students through simulation, it will help in minimizing the patient risk as well as harm. So the traditional method of teaching is see one, do one, and teach one. In the health, earlier we would have seen like 10 or 15 years back, even when I was a BSc student, it was like the teacher used to demonstrate, and then we used to do maybe in the lab on the mannequin or directly on the patient, and then we perform it actually, or we teach our juniors or further. But in modern new methodology, they promote that see one, practice many, and do one. Means if you see once, if your teacher is demonstrating, you see once, then you practice many a times. So it is not very uncommon to say that practice makes a man perfect. So when you practice again and again, it will come to you automatically. And when you become confident, you can go and do it on real patient and do it once or twice or how many times you want to do. So here, I just want to talk about the characteristics of the adult learners. The educational strategies to be used for adult learners, andragogy is different from the pedagogy for the children. So adult learners, they are adults, right? They are independent. They are self-directing. So children are like unwritten pages of the book. So we have to write things in that book. But adults, they are already the written pages of the book. We have to add new pages. We don't have to add new pages, but we have to adjust those pages which is already written. So we don't have to spoon feed the adult learners, but we have to adjust them, give them what they want to gain the knowledge, and they will learn by themselves. So there are 5 assumptions of adult learners: that they are independent, they are self-directing, they have already a great deal of experience, they value learning, which will be helpful in their everyday life. So they don't want to learn something which will not be helpful. And they are more interested in immediate problem-centered approach rather than the subject-centered one. And they are motivated to learn by internal drive than the external one. So if they are willing, then only they can learn. You cannot put a stick on the adult learners and can tell them to learn this and do this and do that. So they learn by acting and doing. That is more beneficial. They learn using their own experience. So this is circle of learning. This is the framework or the model which we use at our National Reference Simulation Center. So it has 5 components. You can see. So it is a framework and it identifies the stages of learning in healthcare, and it illustrates the process from going from knowledge to clinical practice. So if you systematically follow all these steps or the elements of circle of learning, we will have more confident and skilled professional at the end of the course. So it is a learner-centric model. It will help in bridging the gap between the theory and the practice. So as you know, traditionally what was happening, that once the learner or the students, they acquire knowledge and the psychomotor skills, the skills in the lab, they were sent directly to the clinical experience here. So after knowledge and skill, they were sent to the hospital to manage the patient directly. But here we have added 2 more components, that is decision making and simulation in teams. These are the 2 additional components which we have added in the modern educational strategy. So once the students acquire the knowledge through different mediums, whether it is self-study, classroom teaching, group discussion, or through YouTube or internet, and they also acquire skills using their psychomotor skills in the lab, then they have to come to the simulation level for, lab for the decision making. So in decision making, what is very important? We are learning the decision making in our nursing curriculum. Every time we are talking about critical thinking, problem solving, decision making. So why it is important decision making? Because see, it is the healthcare professionals who have to take decision for the patient. So whenever there is a critical situation, it is seen that healthcare professionals, they are lacking in decision making skills. And especially when there is a stressful situation. Sometimes the patient is shouting. Sometimes the relative is shouting. The patient is in pain. The patient is vomiting. Maybe there is an arrest. So in that case, we have to take decision for the patient. And if we talk about 2 patients, no 2 patients are same. We have to manage them differently. Even if we talk about fever, So no two fever patients are same. The cause may be different. They have to be managed differently. So decision making is important. That should be taught to the students. And here in the simulation lab, what we are doing is we are teaching them decision making through virtual simulation. So what is virtual simulation? Here I would like to highlight. So it is like playing video games. Okay, so like we play video games or PUBG or all. So adult learners, they are very much into playing video games. So there is a video of a nurse and a patient or a doctor, healthcare team, and the students have to manage the case within a stipulated time. They have that time, maybe 10 minutes or 15 minutes, and they have to manage the patient. And there are certain options you can see in the picture. So there are certain options coming on the side of the video, and students have to select among the best option what they have to do. For example, if I give you example of cardiac arrest. So if the patient has no pulse and respiration, the nurse is found that patient has no pulse and respiration, what is the first step the nurse should do? There are options coming: start chest compression, start with rescue breaths, call for help, or verify the scene safety. Now, what the student has to select, as the student will click on the right option, the nurse will perform the same action in the video. And they feel like they are doing that. The learner have that fun activity also, and they will learn from that activity also. So they learn taking decision for the patient and how to manage that patient during virtual simulation. So apart from this, we can also inculcate decision making by case studies, by case presentation, which we are doing in the traditional method also. The next component is the simulation in team. Now, simulation in team, it is the fourth cell of the simulation. And after simulation in teams, we are sending the students to the clinical experience and to manage the patient in the real life scenario. Simulation is the fourth cell in the circle of learning. And it is after the knowledge acquisition, after the skill proficiency, and after they learn how to take decisions for the patient, they come in the simulation lab for the simulation in teams. So all other components, all other elements are individualistic. But simulation, it is a group activity. So where the interdisciplinary teams, they come together to learn. So it is never that one person is handling the patient. It is never that nurse is caring for the patient or a doctor is caring for the patient. It is always a healthcare team. Okay, so the healthcare, we cannot provide the care to the patient in isolation. We have to work together. So when everybody has to work together in the real life, they have to practice together also in the simulation. So always the simulation is in teams. So simulation, if I define, it is an artificial representation of the real life scenario so that the students or the learners, they can get the experience of a particular case and they can achieve the expertise before they handle the patient in real life in the clinical or in the hospital. So there is sufficient fidelity. So what is fidelity? Fidelity is actually the degree of realism. How much real is the simulated environment or the patient as compared to the real patient. And the most advantageous point here is it is minus the risk, which is inherent in similar real life experience. So in real life, there are a lot of risks. If we are doing any error, committing any error, it can harm the patient. But in simulated environment, it is a safe environment and students can perform without any risk. So we allow our students to commit mistakes in the simulated environment, which we actually cannot afford in the real life, but the students can commit mistake in the simulation. They are allowed to commit mistakes.
I request all the participants to mute their mics. Thank you.
Yes, so they can commit mistake because when they commit mistake, they learn and they learn from their own mistakes. But only thing which we don't allow our students to do is make any assumption. So students don't have to make any assumption. There is a fiction contract. Students have to take everything as real. Though it is an artificial representation, it is a simulated environment, but they have to consider that everything is real. If they want to do something, they have to do. If they think that they have to do hand washing, they cannot assume that we are doing hand washing. They have to go and wash their hand. Documentation. So little things they tend to forget in the clinicals. But in simulation, they will repeatedly perform these small things and they manage the patient as in the real life. So when they go to the real life, it will automatically come in their practice and it will automatically come in their muscle memory. So it will become a habit of the student that they have to always wash hands before handling the patient, or they have to document, or they have to wear the gloves or wear the PP. So small things also they will learn in the simulation. Okay, so I talked about fidelity. So it is a common industry term which is used in the simulation industry. It is a degree of realism. I have already informed degree of realism and technical complexity of the models and the simulation environment. So how complex is our models and how complex is our simulated environment. So it is dictated by the application needs. So more complex tasks we want to do, we require a model with high fidelity. So we have simulators with high fidelity, with medium fidelity, we have simulators with low fidelity. So it is not that always we have to teach simulation on high fidelity. We can even use the low fidelity models also, low fidelity simulators, and even without any simulator also we can teach the simulation because it is a method of teaching. Any at remote area also we are sitting, we can teach simulation. There can be a standardized patient who can act like a patient, and we can teach our learners without any simulator also. So what is simulation? Whether it is a technology or a technique. So simulation is a methodology, not a technology. It is a process. We don't need, as I mentioned, we don't need hi-fi simulators or high fidelity simulators to teach simulation. We can teach it on low fidelity simulators, the task trainers, or even the standardized patients. Now let me explain about the structure of simulation. So there are three components of simulation, or we can say parts of simulation. First is pre-brief, or we simply say brief. Second is the scenario or the simulation scenario. And last is debrief. So these boxes represent the time which we have to give in a simulation scenario. So for example, if one simulation runs for 1 hour, then in pre-brief, we have to give around 10 to 15 minutes for pre-brief. And in scenario, usually scenario runs for 5 to 10 minutes. And debrief is the longest box. That is the maximum time we are taking for debrief. 30 to 40 minutes we are debriefing the students. So the students will learn through experiential learning during the pre-brief and simulation scenario. That is, they learn through their own knowledge and they learn through their experience during pre-brief and scenario. Whereas in debrief, they are learning through reflective learning. They will discuss and they will reflect back what they have done, how they can improve, and then they can improve in the future. So then they learn through reflective learning. So these are the three important parts. So let me explain a bit about them. So first is briefing, or we say pre-brief. So it is prior to the actual simulation. So pre-brief is why and how of the simulation. We are teaching the participants why we are doing this. What is the importance? So here we are introducing the participants, welcoming them, introducing them to the simulated environment. It is like setting the stage for a safe learning. We tell them the learning objective, why they have come, what scenario we are going to play, and also we explain to them the fiction contract. That is very important. So fiction contract means though everything is artificial, but they have to consider everything is real. And then we also tell about the strengths of the simulator, what are the different parts of the simulators, what they can do and what they cannot perform on the simulators. Also the environment, what all things are there in the environment. We just orient them, all the instruments, all the equipments, what are the capabilities of the simulators, what we can perform. And also, very important is confidentiality and non-judgmental environment. We explain to the participant that you are going to play in a safe environment. Nobody is going to judge your performance. We are not going out and talking about that this person has done a blunder or a mistake. So you can be safely performing. You are here to commit mistake. You are allowed to commit mistake. So, but you are not allowed to assume anything. So we are telling all these things in the pre-brief, and also the role, what role they are going to play in the simulation. So we ask them to volunteer. So we explain that these roles, let's say doctor or the nurse or the patient or the relative. So what role you want to play. So we ask them to volunteer for that. Okay, next is the simulation. So simulation is the real situation. It is the video I have shown you in the beginning of the presentation. That was the second part, simulation. That is a real situation where the learner or the students, they play the scenario and they act out different role of the healthcare team. Maybe some may be playing the role of patient or care providers. So here the facilitator will step back from the simulation. So they are not interacting with the learners, or they are not talking with the participants during the simulation. So this runs usually 5 to 10 minutes. Once the simulation scenario is over, it is followed by the debrief. So debriefing, they are reflecting with the highest potential for learning. So they are sitting, all the learners are sitting with the facilitator and they are discussing how they have performed, what they have performed, how they can improve, what could they have done. So it is very critical. Debriefing, as I have shown in the previous slide, it is the longest walk. 80% of learning happens during debriefing. So it is a learner-centered discussion and guided by the facilitator. So learners are discussing among themselves, though in between the facilitator also guides. So in which the performance of the participants are analyzed and through reflection. So I have explained it is through reflective learning. Through reflection they are learning. So debriefing I will explain a bit because it is very important part of the simulation, and it is like setting the scene. First, there are 3 phases: reaction, analysis, and summary. So in debrief also we have 3 phases. So first is the reaction phase. So once we sit together with all the participants, the facilitator sits with the participants. So the first phase is the reaction phase. Once the student comes from the simulation scenario, they are so much emotional. They have that outburst. We have seen our students crying after simulation scenario, like somebody has played a role of the patient relative. And during the simulation, suppose nurses or doctors were not able to save the patient died. They feel so much immersed in that role that they start crying. The students start crying because they feel that they are actually not playing the role of the relative, but they are actually the relative. So there is so much emotions at the end of the simulation. They are high with emotion. We need to cool it down. So the first phase is reaction, where we are going to ask them how they are feeling. And we need to calm their emotions, okay, so that everybody can be on the same page. Then once all the participants are settled, all the learners are settled, then we move to the analysis phase. In the analysis phase, we analyze what we have done. Here, the facilitator will guide. Okay, so facilitator will guide. Facilitator will not point on the mistakes that I have seen you have done this thing wrong or this thing can be improved. No, we are not pointing to the mistakes of the students. If we do it, then the students will not come up and they will not speak next time. So here, the students, they are discussing, not the facilitator. It is an educator guided with learner insight. So learner will insight and look back and think what they have done. So we ask the students, can anyone tell the sequence of the events? What happened? How it happened? When they revise the sequence, they will themselves come up with, okay, we left this, okay, we can do that. If not, then facilitator can fill the gaps wherever is necessary. The facilitator is not pointing, but only guiding the discussion. So students learn by themselves. We can ask some non-judgmental questions, and the student should not feel embarrassed that yes, we have done something mistake, and it is not we have to take the name of the student. We can take the name of the role what they have played. So instead of saying, Madhu, you have done this thing wrong, we can say, yes, I saw that the junior nurse has forget this. Okay, we can put forward our observation that she wanted to do this. So can you talk about that? So we will ask them to talk about what they have done. When they talk about, they will themselves realize, okay, I have forgotten this, or we can do that thing. The next time we can do it better. At the end, we will summarize. So summarizing the whole learning which we have done during the debriefing. So summarizing what they have learned. When they were analyzing, it is not only the simulation. So we can incorporate what they have learned in the classroom, the knowledge part. There, whenever the students are coming with some point, okay, we left it. For example, if I give you an example, so we have seen the students are missing small things. Like if we are running a simulation on the normal vaginal delivery, the students, they forget to note the time of birth of the baby. So what will happen? But during debriefing, we can come with that point, or maybe the student themselves will come with the point that yes, nobody in the team noted the time of birth of the baby. What will happen? What is the significance here? What will happen if they will not note? It is a small thing. Instead of writing 6, they can write 6:05 p.m. There is no big deal. But we have to emphasize the significance there. What is the significance? Golden minute is lost if the baby doesn't cry, if we have to resuscitate the baby. If we don't know the time, how we are going to know it? So that thing, then once the point we have come with that point, we can go and teach the neonatal resuscitation, maybe the protocol. Also there we can discuss during the analysis phase that this is the protocol, and during the golden minute we have to check this, and how many seconds, 6 seconds, then how we can calculate. Then knowledge part also we can incorporate during the analysis phase. So once we are done with analysis, we summarize the whole learning of the debriefing. So summary is not of the simulation, but that of the learning which happened during the debriefing. So once we summarize, it is not the facilitator who has to summarize, it is the learner. So I am again and again saying it is the learner focused discussion. So learners themselves will summarize, and then they will give us at least one point, take away message, take home message. So we ask them, what is the take home message from today's simulation, what you have learned? So they will tell at least one take home message which can help them in future, and they can apply them that point in their clinical practice. So remember, so this was the whole simulation, how it occurs. So there are certain points that prior knowledge and skill competency and decision making of a given topic is the key for students to come for simulation based education. We cannot run simulation if the students doesn't have a knowledge of that particular subject, of that particular topic. We think that, okay, we are going to run simulation on pneumonia. If they don't know what is pneumonia, how we have to manage the patient, they have not attended the class on pneumonia, or they don't have the skill of administering oxygen, or doing the nebulization, or administering the drugs, IV. So we cannot run simulation. That is the key. The circle of learning, do you remember? After those 4 components, only the simulation and teams occur. And we have to follow the structure of simulation. It is not that only, okay, you role play, okay, you forget pre-brief or debrief, only we say students are coming, we are less time, we will only run the scenario for 5 to 10 minutes, you just play the scenario, these are the roles and you play the scenario. So if we are not debriefing, students have committed some mistake and we are not debriefing at the end, then what will happen? They will go with the wrong message. They will leave the simulation lab with the wrong message. Okay, I did this, I didn't know the time, so it is okay. We can forget it. So we don't want our students to go with the wrong message. So it is very important to do pre-brief, simulation scenario, and then debrief. We have to follow the structure. And pre-brief is also very important. If you have not pre-briefed your students that this is the simulator, you can do all these things in the simulator and these things you cannot do, or you have not oriented to the simulated environment, during the simulation, they will commit mistakes. They may, like for example, we have the IV port, but we tell our students that do not use this IV port to inject the medication because it will damage the simulator. So they will do it and they will verbalize it. But if we don't tell these things in the pre-brief, they will inject the solution in the IV port. And what will happen? It can damage the simulator. So similarly, pre-brief is also important. If they don't know the learning objective, they will just do something, but not according to the learning objective. So safe learning environment is the key. So we have to again and again emphasize that nobody is going to judge you. It is a safe environment. There will be confidentiality. Nobody is going to out and talking about your mistakes. So we have to make our learner very safe in the environment. And debriefing, it is the potential for learning through reflection. So debriefing, 80% of the learning happening in debriefing. So it is the major part of the simulations. And adequate preparation and practice help. This is very important. Not only preparation of the students, but also the facilitator, the trainer who is going to take the simulation scenario. She should be prepared adequately. That yes, if they are not prepared what they are going to do, definitely students will not perform and they will not come up with what is expected of them. So simulation, it facilitates learning through immersion, reflection, feedback, and practice. So immersion during when they are playing the role, they are doing the simulation scenario, they are totally immersed in that role. And during debrief, they are reflecting and maybe the facilitator is giving feedback, filling in the gaps. If they are not coming up with some points, the facilitator is coming back with some points. So they are learning through reflection and feedback. And last is practice. They are again and again practicing. So we can perform re-simulation here. If students have done a blunder during their simulation scenario, we have taken the students for debriefing, we have discussed with them, and they also come to know, okay, we have done some blunder. We need to repeat this simulation. We can go for re-sim. So in briefing, we can leave the pre-brief because already the students were pre-briefed, and we will just perform the scenario followed by the debriefing. So it is seen that simulation will help in individual providers and teams to adhere to protocols and standard operating procedures. According to some studies, a study done by Zwain and Advani in 2008, it allows implementation of protocol-based practice. So it is seen that second-year medicine students, if they are taught through simulation, according to they adhere to the EHA guidelines 68% of the time. Whereas third-year resident students, when they are traditionally trained, they are adhering 44% time only. So there is a difference if we are teaching through simulation and we are just teaching through the traditional method. So this you have seen in the video also. There's a very big study by the National Council for State Board of Nursing 2015, which has found that high quality simulation can substitute up to 50% of the traditional clinical hours across the pre-licensure nursing curriculum. And this is the study which are in the foreign, but in India also the IMC along with JPIGO and SDT University, we are conducting a study here. There we want to assess if we substitute at least 25% of the traditional clinical hours, will it make some difference in the student performance? So we are also performing the study in the National Reference Simulation Center, where we are trying to replace the 25% of the traditional clinical hour through simulation. So what are the characteristics of trainer? I am again and again saying facilitator. Who is a trainer? The trainer is an instructor or a facilitator. So trainer, we say facilitator. We don't say teacher or we don't say trainer. We say facilitator because we facilitate the students. So students, we are not spoon feeding, but students are learning by themselves. They are the adult learners. We are just facilitating, focusing on their group attention, trying to engage everyone. Okay, we are not controlling their behavior, controlling them, do this, do that, but we are giving that safe environment that they do what they want to do in this. This is a simulated environment, they can commit mistakes. And also, the facilitator has to be a very good listener, very patient listener. They have to have that curiosity to listen to these students. It is not that student during debrief, students are saying something and the facilitator is not paying attention to the learners, what they are saying. Okay, and the facilitator has to be a very good observer. When they are performing, when the students are performing the simulation scenario, what all things they did good, what all things they left, we have to take a note of all these things. So a facilitator has to be a very good observer, very good listener, and they have to gather information. They have to balance planning and intuition. Planning. Some things we plan, okay, we are going to do this, but some things come on the spot. That is intuition. So we have to balance both planning and intuition. So in traditional training, it was more focus was given to the trainer and less to the participant. But in simulation, trainers take the back seat. It is the participants who are more focused and it is focusing on the participant learning. So if we talk about the styles of facilitation is like parent holding a bicycle and then letting go. We are teaching them, we are introducing the students into the environment, simulated environment, and then once they enter, we let them go, they do, we tell them, okay, these are things, this is expected of them, we orient them to the environment, then they can commit mistakes and learn from their own mistakes. So innovation must be measured by its impact. Simulation-based training must be measured by the number of lives saved after training. So I end my presentation and I want to give a glimpse of our activities at National Reference Simulation Center, SDT University. So it was established in October 2018. We are doing many activities since 2018 and I will just give a glimpse of recent activities we are doing. We are doing a 6 years TOT, training of trainers on simulation-based education. Also, we are doing online simulation-based education. During this COVID era, our students are not coming to the classroom, so we are doing a virtual simulation, online simulation. There, we are recording the video of the scenario, and then students are doing the debriefing. Also, we are doing this IANN and NNF collaborated NRP neonatal resuscitation program, then capacity building program of midwifery faculty by INC and UNFPA, and AHA certified BLS ACLS course, hands-only CPR training for the non-teaching staff, non-medical students, security guards, drivers, and the villagers. And also we are doing the faculty development programs also of the trainers. We are also getting trainings to develop ourselves. And also we are training, skill training of the medical and nursing students and even the nurses and induction training of the nursing staff. So thank you for your patient listening, and I would end my presentation by welcoming you all to our National Reference Simulation Center at SDT University. We are conducting training regularly, and I'll be posting about that training also. And even at INC website, you can see. So whenever there is training, you are most welcome to come here and visit our center and attend our trainings. Thank you.
Thank you so much, Mandeep, for the excellent presentation and overview on simulation and what it is actually. And thank you so much for your invitation to visit you also. Hopefully, with the COVID situation stabilized, we should be able to visit you. And Yeah, as you have said, simulation is the way forward. And traditionally, medical and nursing training was so much focused on skill competence. But simulation has the ability to add critical thinking and behavioral change along with the skills. And the new Indian Nursing Council curriculum also, it is going to bring a pivotal change in the way nurses are to be trained. And nowadays, we are concerned about patient safety and the psychological safety of our students also. And for that reason, simulation has to take a central stage in the training of nursing education. Very well covered. Is there any questions from the audience? You can unmute and ask. I could not see any question in the chat box. Or anyone would like to comment?
Ma'am, good morning.
Good morning.
It was a very well explained presentation, ma'am. It was very useful. And ma'am, I wanted to know whether can we learn any procedures through simulation model, simulation technique, ma'am?
Yes, ma'am.
Okay, ma'am. Thank you.
Whatever we want to learn, but only thing is students should have knowledge and the skill base. So, for example, like pneumonia, I was taking, if we are going to simulate a patient with pneumonia and the students have to manage, then they should know that necessary skills also, and what is pneumonia, how we have to manage the patient, and what all skills is required. They should know that oxygen administration, maybe positioning, how to in positioning also, even students, they don't know how to handle the bed. So they don't know how to handle the bed, how to move, how to give semi-power position. They get stuck there. So all those things, little things they should know, giving IV medication or medication to the patient, and then nebulization, and maybe like if the patient goes into arrest, then how to intubate, how to give CPR. So all those skills first we are teaching, and then when they feel competent, then we are going for the simulation scenario. So I think all procedures, it is not procedures, it is managing the patient. So we are teaching the procedure in skill training, but we are teaching them how to manage the patient in simulation scenario.
Yes, ma'am. Thank you, ma'am.
So adding to that, to say that as faculty, we are sometimes, confused whether just the skills training is a simulation or is it scenario based is a simulation. So simulation based training actually encompasses all this. There's a very good article by Peter Weinstock and team from the CHOP, Children's Hospital of Philadelphia, and that talks about the zones of simulation. So we start from zone 0 to zone 4, whereby zone 0 is just task training. And then the noise, that is the clinical witness, and the scenario comes in zone 2 and zone 3. And in the zone 4, actually the practice is happening in the clinical area on the patient. And the real debriefing happens. And that's for very experienced team members. So for nursing education, we can start with zone 0 to 1 in the first year of training, and as they are getting more exposed to medical, surgical, and pediatrics and OBG, etc., we can increase the noise. We can go to we can introduce them to scenario-based learning, complex scenarios, how to work in a team. So there are so many things in simulation. Actually, we cannot cover in 1 hour. And I highly recommend the article. I'll just repeat the name of the author. It's Peter Weinstock. That article is. Yeah, any other questions? So if there are no other questions from the audience, I would like to ask one question to Sandeep. So as nursing faculty, we face challenge on how to incorporate simulation training. So what are your tips?
Ma'am, actually here in SDT, what we are doing is once the students, they are getting the knowledge, like maybe the first year students are not coming to the simulations in lab, but second year onwards, once they get the medical surgical skills also, medical surgical is introduced, so they are coming to the simulation lab. So we are dividing, we have 100 students in one batch, and we are dividing them, and like 25 students are coming to the simulation lab, 25 going to the hospital, and 25 are going in the community, and 25 to the civil hospital we are also sending. So likewise we are sending, and we are rotating them. So we have that lab, we have various parts. So we are dividing those 25 students in different labs inside of the simulation lab. So in rotation we are doing this. So but it is not that on the first year only or in the second year suddenly we are taking them for simulation. We have to make sure that their knowledge and the skills has to be covered in the nursing lab. So in the college we have the nursing lab, they are covering the skills there also, and when they are coming to us also, we are making a plan, a schedule through which we are covering their essential skills. So in first year, they are in nursing foundation, they are learning those skills. So we are re-emphasizing those skills here when they are coming in second year also. Then third year students are also coming for pediatrics and OBG, and internship students also are coming. So on rotation basis, we are doing it. So, but it takes time. Like I told, one simulation, it takes around 1 hour. So it is not always possible. For example, if I have 15 students or 10 students, so we are dividing them. So if we have even 5 students also, not all students can perform the simulation scenario. So we like suppose 4 students are performing the simulation. One is a junior nurse, one is a senior nurse, one is a doctor, one is a relative. Maybe the other students, suppose 4 or 5 students are observer. They are observing the simulation scenario, and then later on the next simulation, we can give chance to those 4 or 5 students which were not there on the hot seats, and they can perform that simulation scenario, and those who performed in the previous scenario, they can be the observer. So they will get a chance of all the students will get a chance on sitting on the hot seat, performing the role, and experiencing what when they are playing the role. So likewise, it is not that always all the students will get chance, but on the rotation basis, they will get chance in one or another simulation. And during debrief, it is all the students who have to sit together with the facilitator, and they have to attend the debrief.
Okay, thank you, Amandeep. So do you put this simulation practice hours in the clinical rotation plan itself?
Yes, ma'am.
Do you take it out from the clinical hours?
Yes, ma'am. Clinical hours only. So I have told you that we are doing this study. So 25% of the clinical hours they have to, for all the subjects, they have to be in simulation.
Thank you.
Even first year students also in nursing foundation, though they did not come because of the lockdown, but for them also at the end of the first year, we have kept their nursing foundation hours. So they didn't come to it from my mind because of the lockdown. They were also supposed to come to us. So first year students also at the end of the first year, we can ask them to come for the simulation, and we can run the basic simulation like admission, like discharge, transferring the patient. So simple skills they have learned, and then a simple procedure, simple scenario we can give them. It is not very high-fi procedures or high-fi scenarios we have to give them. So even for first years we can meet.
Right. So I think we are, we have to wind up the session because we have reached the end of the time. So I really want to thank all the listeners for tuning in today for this #3 webinar. And I once again thank Ms. Amandeep for the excellent presentation. And I hope that all of you have filled the feedback form. You will get a self-generated certificate upon filling the feedback form. So Principal Ma'am is there. I think she had gone for a meeting.
It's okay, ma'am.
So until the next webinar event, here's bye-bye from our side. Thank you so much.
Thank you, ma'am. Thank you. Thank you for participating.
There is one query in the chat box. It seems.
Oh, okay.
Okay, somebody is asking for the 12th June certificate. Can you please give your name? Whoever is that? We will note it and we will send you your name in email, please. We will send it to you by email. Given? All right, we have noted it. So thank you so much. Bye-bye.
Thank you, ma'am.
Really a wonderful session. And I have personally visited to SGD University and you were explaining there also. So every component you have very clearly explained. Thank you so much.
Thank you, ma'am. Thank you, ma'am, again for giving the opportunity.
Yeah, more frequently we will call you to address our students, you know.
Okay, ma'am.
Probably we have to learn simulation as a method of education.
Yes.
We call you as a speaker, part of their nursing education subject, in which you can explain all these concepts once again to the students. Every year we will call you.
Yes, ma'am. Thank you, ma'am. Thank you, ma'am.
And we are proud of you. And thank you, Levis, for your perfect coordination. Thank you and thanks for supporting us. Thank you.
Thank you, ma'am. Thank you so much.